Hello, everyone. Today I have the pleasure of introducing our Neurocritical Care Fellow, Dr. Alyssa Runco. Dr. Runco completed her undergraduate degree at Texas A&M University, where she had a bachelor's in both biology as well as poultry science. She completed her medical degree at University of Texas Medical Branch, School of Medicine in Galveston, Texas, and then went on to complete her went on to complete her child neurology residency at Baylor College of Medicine and Texas Children's Hospital. Alyssa joined us as a Neurocritical Care Fellow during this present academic year, and I'm happy to let you all know that she will be joining us as a faculty member. Today, Dr. Runco is going to be discussing acute necrotizing encephalopathy with us, so I'll let her take the stage. Dr. Runco.
All right. Thank you for that introduction. So yes, today I'm going to be talking about acute necrotizing encephalopathy. It's an interesting disease with a high mortality. So I think that leaves us lots of room to learn and improve upon for our patient outcomes. And so first I'll start off with a recent case example of a patient that many of us have taken care of this year. Oh, let me advance. Okay, there we go. So this was a 9-month-old, previously healthy and developmentally typical female who presented with 3 days of fever, emesis, and congestion in the setting of or with new onset focal seizures to an outside hospital ER. These seizures were described as gaze deviation with right or left-sided arm and leg rhythmic twitching. Other than that, she was previously healthy with no other medical problems, had a pretty unremarkable birth, was born full term. There's just a little bit of preeclampsia, but otherwise delivery was normal too. Interestingly, when you talk to mom, the family history was pretty interesting. Mom herself had a history of meningitis with seizures at age 5. She said they went away after that. She doesn't really know anything else. And then the patient's sister had an episode of speech regression around the age 2 that had not been worked up, and mom said that she was just then starting to say a few words again. And then there's also a maternal aunt with seizures provoked by illness and a maternal cousin who's only 5 years old with seizures in the setting of fever. So at that outside hospital, she was hypotensive, so she received a fluid bolus. They gave her some Keppra because she was having seizures, and they sent some initial lab workup and did a CT head. The initial labs were pretty unremarkable except for a mildly elevated AST, and then the CT head was reportedly normal. There she continued to have further seizures, so they also gave her a phosphatonin load, then transferred her here to us where she was started on continuous EEG neuromonitoring. We kind of repeated some of those labs and then sent a respiratory viral panel that was negative for the viruses tested and started her on some empiric microbial therapy. And then here is her CT head done at that outside hospital. We ourselves looked at it since we know outside hospitals usually have adult radiologists looking at them, and you know that there's these hypodensities in the bilateral thalami, as well as you can see there's a hypodensity here on the right side as well. And this is her initial EEG when she first came in. It was continuous symmetric. It did have reactivity, and here we're seeing sleep, and so she actually has these nice, beautiful, symmetric and synchronous sleep spindles. So this is all normal for age. And so then while she was here as part of her workup of new onset focal seizures in the setting of fever, we did MRI and LP. This is day 2 of coming in. And so here I have on the left the T2 sequences and then DWI, followed by the ADC sequences. And I actually added on the SWI sequences here in this last column just because I think it helps show the degree of necrosis she had. So here you're looking at, she has bilateral expansile lesions in the thalami, pons and external capsule with associated hemorrhage and necrosis. And then there's also these additional areas of diffusion restriction in the right temporal lobe, as well as the bilateral mesial temporal lobes. And then I didn't show them here, but she also had vessel imaging that was of the head and neck that was completed and unremarkable. And then her CSF analysis showed elevated protein without pleocytosis. So that evening, she was noted to be getting sleepier and not even waking up to feed. And then after we saw the MRI and CSF results, she was started on IV methylpred for a 5-day course and given a dose of tocilizumab. But it was also noted in that evening to overnight, she started having more seizures of right posterior onset that then would spread and progress to non-convulsive status. So here's an example of one of those. And so for this, she received phenobarbital. And then these labs do take time to come back, but just for completeness, she also had CSF meningoencephalitis panel that was negative. She had some functional metabolic testing that was negative. These included like guanidinic acid, acyl carnitine, and CSF lactate pyruvate. Then we also did serum and CSF cytokines, which were interesting. She had elevated IL-6, IL-8, IL-10, and some TNF alpha in the CSF as well. And this is just an overview of her hospital course in general. So we already talked about she first presented with seizures. On day 2, she had her imaging that prompted us to start immunotherapy treatment on day 2. And then in that evening, she still had rapid decline in her mental status and continued on with seizures for a few days. But they were later controlled with 3 anti-seizure medications, levetiracetam, phenobarbital, and lacosamide. And then by day 4, she started having some improvement in her mental status. She was now spontaneously opening her eyes and no longer requiring like really deep stimulation to even open her eyes. And this is also the last day of her seizures. She continued to progress and was transferred to inpatient rehab on day 9. There she remained until day 19, where she went home. She was still on those 3 anti-seizure medications at discharge. But it was noted that her exam was much improved. She was awake, she was interactive, and it was a non-focal exam, but she still had some truncal hypotonia. So this was a case that was presenting of acute necrotizing encephalopathy. So what is this? Acute necrotizing encephalopathy, or we'll call it A&E, just because it's faster to say, was first described in Japan in 1995 by Mizuguchi and his group. It's a rare disorder that is triggered by viral infections, and it can cause seizures, loss of consciousness, and rapidly progressing encephalopathy. Most cases will have 3 different phases they'll talk about. So first is the prodromal phase. That's characterized by the viral symptoms like respiratory and GI symptoms like cough, vomiting, or diarrhea. And then you move into an acute encephalopathy stage that typically begins 1 to 3 days after that prodromal phase. And this is characterized by like a progressive deterioration of neurological function, altered consciousness, can even progress to coma. There's seizures and abnormal muscle tone. And then the last phase is just recovery. And so most cases of A&E will occur sporadically and are non-familial and non-recurrent. But there are some cases that are due to a genetic etiology, which we can talk more about later. The majority of cases occur in early childhood, especially between the ages of 1 and 4 years old. But there are a few adult cases reported out there in the literature. It occurs equally between males and females, and there is some suggestion from one case series in China that there may be a prevalence in the winter and spring, but it might also just be that it follows the pattern of increased like respiratory viral illnesses. And then the mortality rate has been described anywhere but from 25 to 50% in the literature. And then there is some evidence that there's a higher prevalence of A&E in East Asian countries, and that's attributed to different HLA alleles that are more prevalent in those populations. But it does still occur globally, and that's just thought there's different like genetic environmental factors that contribute to this. So in addition to the neurological complications of A&E, many patients also present in shock and require significant resuscitation. They often also have elevated liver transaminases without an ammonia elevation. This like lack of ammonia elevation can help distinguish it from other like metabolic mimickers. They can also have thrombocytopenia and other nonspecific markers of inflammation, like elevated LDH or elevated CRP. And then on cytokines, there is an association with the increased IL-6, IL-8, IL-10, and TNF alpha. And there's some evidence that higher IL-6 levels have been previously associated with a higher rate of death in a cohort compared to a different cohort that experienced improvement. And that group of patients who had died with that really high levels of IL-6, it was like really, really high, like levels over 500. And then A&E also does not occur as a direct effect of an infectious process itself. And so you're not going to see the inflammatory cell infiltration or like actual like microbial tissue in the CSF. The CSF is analysis is going to show you an elevated protein, often greater than 50 to 100, and it's going to not have pleocytosis. So the most common viral trigger that's associated with A&E is going to be influenza A, but also influenza B. And then it can be associated with any of the other classic viruses. And so things like paraflu, varicella, Coxsackie have all been associated with cases of A&E. So then moving on to our classic imaging features seen in acute necrotizing encephalopathy, you'll typically see these symmetric bilateral thalamic and brainstem lesions, and then they can also have hemorrhage and necrosis seen as well with them. There's also this interesting like ring-like pattern on the ADC map that's been described in A&E, where you see these 3 rings of high, low, high ADC signal. And so what this is at the center of the thalamic lesion, there's this high ADC sequence you see here, and this indicates hemorrhagic necrosis. And then you have this middle layer of high ADC or a low ADC signal that indicates cytotoxic edema. And you can think of this kind of similar to like the cytotoxic edema that you'll see in acute ischemia or like a stroke. And then this outer layer here is the high signal surrounding the thalamic lesion is indicating the vasogenic edema. And so most cases of acute necrotizing encephalopathy occur sporadically and are non-familiar and don't recur. And in 2009, Dr. Nielsen, who is actually here at PCH now, and his group described the link of RANBP2 mutations and familial recurrent A&E. And since then, A&E associated with RANBP2 mutations is referred to as A&E subtype 1. So the most commonly described mutation is a change of threonine to methionine at the 585 position, but there are several other mutations described. Most commonly is inherited in autosomal dominant fashion, and there are heterozygous mutations in RANBP2. These are associated with 75% of familial recurrent A&E cases, but the penetrance is estimated to be low, or it's only like it's about 40 to 50%, depending where you look in the literature. This basically just means that there are carriers within the same family of affected people who don't have disease and do not have A&E. And then there's some evidence from some consanguineous families that there might also be autosomal recessive inheritance. And then there's also other genes that have been implicated in acute necrotizing encephalopathy, like CP2T2 and RNH1. And so when you have a patient with A&E, it would be pertinent to consider genetic testing in any of them, but especially if they have a history of a recurrent attack or any family member who has a history of neurologic symptoms in the setting of a febrile illness. The other thing that would be good to know when you're sending genetic testing for patients with A&E is that RANBP2 or other changes with RANBP2 can also cause other diseases that aren't A&E. So like chromosomal translocations that have a fusion of RANBP2 with a different, it's like a lymphoma kinase gene, those are associated with like different like lymphomas or myelofibroblastic tumors. And those patients don't get A&E. So different phenotypes. Okay, and so after the identification of the RANBP2 gene, there was this distinction to subclassify the sporadic and familial cases. And there are different important distinctions also between these two. So in sporadic A&E, you're more likely to see the elevated liver enzymes and systemic involvement versus in A&E1 or the familial A&E, you're not going to most likely have elevated liver enzymes. And then both will have those bilateral thalamic lesions that we showed earlier, but in familial A&E, it's also associated with other lesions as well in the mammillary bodies, amygdala, and the medial temporal lobes. And then also what's important to know, especially for counseling families, is that in sporadic A&E, it's very rare to have a recurrent episode versus in familial, they're more likely to. It's estimated about like a half of patients with familial A&E will experience recurrent episodes. And so then why does A&E occur? Sorry. Okay, so normally when you have a viral infection, you get this local activation of the mononuclear macrophage system, and that leads to secretion of cytokines, and then further lymphocyte activation, which plays a role in defending off viruses. But under certain conditions, this can get dysregulated, and you get excessive cytokine release, and this can then go on to affect other organs and injure them. And that's why we'll see renal injury and elevated LFTs and elevated troponins and things like that. And then for the nervous system, these excessive cytokines like IL-6 and TNF-alpha are associated with increased blood-brain barrier permeability, and this occurs because you get like decreased stability of those tight junctions, and then it causes the endothelial cells here to produce thromboxane 2 and prostaglandins, which then you go on and activate your astrocytes and microglia, you're damaging your oligodendrocytes, and then you're getting neuronal atrophy and necrosis. And then I haven't seen any evidence of anyone trying COX inhibitors, but it has been proposed as like a potential treatment modality to modulate this immune response, causing increased blood-brain barrier permeability at the endothelial cell level. Okay, and so the next, talking about the genetic etiologies of A&E. Sorry, I hope I don't lose you too much with some cell biology, but I think it is important to help understand like how these patients' phenotypes are, and the disease pathogenesis can guide our treatment modalities. So this is RAMBP2 protein, and it forms a cluster along the nuclear pore. There's like 5 of them here, and this is here the nuclear side of the protein, and then you have these like cytoplasmic filaments. And so RAMBP2 is one of the main components of the cytoplasmic filaments of the nuclear pore complex, and it plays a major role of protein and RNA cargo transport between the nucleus and the cytoplasm. And so there's different components. This component here, the N-terminus leucine-rich region, contains these like phenylalanine glycine repeats, and this is what's going to facilitate the nucleocytoplasmic transport. This is also where most of the mutations occur for A&E1. And it's interesting because just having this portion of protein is enough for cell viability, but having the ability of this portion of protein to associate with mRNA shuttling proteins is critical for efficient RNA export. So efficient mRNA export, you would think, would be important during times of stress, like a viral respiratory illness. And so then next, RAMBP2 is also important for maintaining and regulating gene expression via mRNA export and translation. And so this area here will help interact with proteins that target certain mRNAs for silencing, and IL-6 is one of these proteins. And then this will also facilitate translation of mRNAs containing those alternative mRNA nuclear export elements. If you remember way back when to cell biology, those are what were important for your endoplasmic reticulum proteins, your secretory proteins, and your mitochondrial proteins for cell trafficking. And this may affect gene expression and lead to reduced production of secretory proteins. And these RAN binding proteins, there's 4 of them, are important for the actual like nuclear export. And then you're going to also have this like sumo ligase area that's important for directionality of transport if you want it to go one direction. And then the last important thing, sorry, I know it's a lot of cell biology, is that this protein can affect mitochondrial function, as the mutations can result in alterations in energy production and immune signaling. And this is done because RANBP2 dysfunction can result in mislocalization of those cell products, including mitochondrial hexokinase 1, which is important for glycolysis. And then if you have decreased ATP production, you're going to have mitochondrial stress. Okay. And then so the other way this plays a role in our mitochondria, in is that it affects our innate immune signaling. If you remember way back when we learned about the mitochondrial inflammasome. But basically, when there's a mitochondrial dysfunction, the mitochondrial inflammasome is activated, which then leads to production of these like pro-inflammatory cytokines, and then potentially even that cytokine storm that we think of in this disease. Okay. So moving on into an effort to better characterize the severity and outcome in A&E, there was a severity score that was developed in 2014, also out of Japan by Yamamoto's group. And so they developed this by creating a score of clinical variables that correlated with neurological outcomes in a cohort of about 40 patients, and they weighted each item determined the strength of the correlation with patient outcome. What's interesting is they also then applied the score prospectively to a new cohort of about 30 patients just to validate it. And so here you'll see the presence of shock was given the heaviest weight of 3 points, and this because it had the strongest correlation to outcome. Then they also included brainstem lesions and older age, and evidence of thrombocytopenia on admission. The strengths of the scoring system is that it was validated in multiple cohorts and on subsequent studies too as well. And it's really practical to use at the bedside. But I think it's important to also note that it doesn't account for other factors like cytokines or genetic etiology or even time to treatment, especially since if you notice the study this was created in 2014, that's prior to tocilizumab being more commonly used in treating this disease. And then I think also just practically, like most things in the neuro ICU, it's helpful that it can be a tool to guide prognosis, but it should be used as a tool and a piece of information, not like an absolute prognosticator. Even in this cohort of patients, they had patients with high severity scores who went on to have like none or just moderate sequelae. And some of their patients in the lowest group did have severe sequelae or even died. So then moving on to different treatment modalities that have been used for acute necrotizing encephalitis. There's no standardized guidelines, but most people focus on immunosuppressive interventions while also supporting symptomatically. Those symptomatic things are going to be things like treating seizures, supporting the blood pressure and other multi-system organ failure. And then people most often use IV steroids, but IVIG, Plex, and tocilizumab have also been reported. And then other strategies that have been proposed in the literature, but I haven't actually seen any cases using these, talk about COX inhibitors, hypothermia, mitochondrial support, and serine protease inhibitors, which unilastatin is the one that's like proposed. They've used it in Japan, but it's not even like approved in the US. And so steroids are proposed to work by treating the cytokine storm and actually decreasing inflammation in general. It's thought that it can provide protective regulatory effects on the mitochondria to allow neuroprotection and synaptic plasticity. And it also limits the extent of cerebral edema associated with inflammation just in general. So in 2009, we had our first case series that evaluated any kind of immune therapy in A&E. And so this was done by Okamura's group in Japan as well, looking at early steroids or no steroids used in patients without or with brainstem lesions. So they had a retrospective study of 34 children, and they found that early steroid use within 24 hours of onset was associated with better outcomes, especially in the patients without brainstem lesions. And it highlighted that early steroid administration led to good outcomes in 7 of the 12 patients compared to poor outcomes in all 5 of the patients who didn't get early steroids. And then another proposed immune modulator therapy is tocilizumab. This is a monoclonal antibody targeting the IL-6 receptor. And it's thought that it can help restore the integrity of the blood-brain barrier and preventing the entry of systemic cytokines into the central nervous system. The most common adverse effects associated with tocilizumab are neutropenia, thrombocytopenia, and elevated transaminases. And so these potential side effects, I think, are what initially might have caused some hesitation in using it in A&E, since transaminases and thrombocytopenia are common in this disease. And then in 2019, we did have our first case series of, a robust number of 3 patients using tocilizumab. All 3 of them received IV steroids and tocilizumab within 32 hours of their encephalopathy onset. None of them had side effects, which was important. And then of the 3, 2 of them had a very short illness course and had excellent recovery, back to an MRS of 0. And then there was 1 patient who had a slower recovery and had eventual mild disability. And then, though it was a small case series, from that they concluded that IV tocilizumab appeared like it might be safe to use in A&E, and may also improve outcomes. And since the series, there's been numerous other cases reported using toci as well. So next, there was this large meta-analysis published a couple of years ago by Shell's group in Hopkins. And it was a meta-analysis of 158 patients looking at high-dose steroid therapy initiated within the first 24 hours of neurologic symptom onset. And they showed significant improvement in morbidity and mortality outcomes. So this first graph in A shows outcomes of patients treated with early, late, or no IV steroids. And patients treated with early steroids had better outcomes than those without early or with late steroids. It's important to note there wasn't a consistent time frame of what was considered late, but early was within 24 hours. In B, you'll see that there were no observed differences in patients treated with or without IVIG. And then in C, they looked at a combination of early steroids plus IVIG, and it did not lead to superior outcomes than steroids alone. And then in column D, you'll see they also evaluated the use of tocilizumab, and there was a trend towards a percentage of patients with a good outcome in those who received toci, but there wasn't enough to reach significance. But there was a significant improvement in patients treated with a combination of early steroids plus tocilizumab. And then they also looked at plasma exchange, and they noticed there was a significant difference in percent survival after treatment with plasmapheresis compared to those who did not receive PLEX. But they do note that many of their patients who received PLEX had a milder presentation, as those who were more severe, they had more systemic organ dysfunction, would need more time for stabilization and time to get a line, which is not as feasible to do in an unstable patient, a hemodynamically unstable patient. And then they also note that the patients who received tocilizumab may have been more on the severe spectrum because it was less of a standard in the early treatment of A&E in the patients they were analyzing. The other thing that's interesting to note in all of these, almost 160 patients, none of them reported having any patients of a genetic etiology of RAMBP2. So it might be that these results are more applicable to sporadic A&E cases, but I don't think there's enough evidence to differentiate either or. It's just interesting. So next, I was just going to talk about the experience here at PCH. This is a study that was done looking at 7 patients who were diagnosed at A&E here between 2011 and 2020. I'll say we've had more cases since. But so they were looking at the primary outcome of MRS score at 6 months post-injury. And then they had secondary outcome measures looking at how long patients were hospitalized, their demographics, genetic results, initial labs on admissions like the thrombocytopenia and transaminitis, whether they had shock or not, and then if they had epilepsy or not at follow-up 6 months later. And so it's interesting that all patients had genetic testing for RAMBP2 and all of them had non-diagnostic testing. 2 of them had flu A, 2 of them had flu B, and then the other 3 had rhino, CMV, and parainfluenza. Patient 6 here had a recurrence 1 year later, but they didn't include the data from the occurrence in this case series. And then patients 1 and patient 3 here, they're siblings. And patient 1 is the only patient who didn't receive treatment And that patient died on day 6 of illness. And if you'll notice, patient 3 who came in, the sibling, got treatment as soon as they came in, just knowing their family history, and had a pretty great outcome. Where is it here? MRS of 0. And so the type and timing of treatment, whether it's IV steroids, IVIG, or tocilizumab, the patient's EEG characteristics, MRI brain characteristics were also analyzed. And you can see here in this graph that early immune modulated therapy was associated with improved functional outcomes. You'll see they had lower MRS scores. And then next over here, if you see the A&E severity score, which many studies also use, it was noted that it was not associated with a poor functional outcome, but it did associate significantly with an increased length of hospital stay. And it might just be that having that multi-system organ involvement correlates to a longer hospital stay. That's based on the severity score, accounting for more things that indicate other organ involvement. It's also noted that older age, presence of brainstem lesions, and were also associated with longer hospital stays. And so then lastly, they also looked at sleep spindles, and these were evaluated because these can serve as a surrogate marker for intact cortothalamic function, and since A&E has a predilection for affecting the bilateral thalami. And so the presence of normal EEG sleep spindles was associated with improved functional outcomes as indicated by lower MRS scores. And so you'll see here, this is patient 3 on the left, A, and they had these nice bilateral symmetric sleep spindles, and they had a favorable outcome at 6 months. Their MRS was 0. And then to the right here at B, you'll see patient 7. He did not have sleep spindles on the right, actually also had some interictal epileptiform activity, and he had a poor outcome. His MRS was 5 6 months later. So then in conclusion, I think I talked really fast, sorry. Acute necrotizing encephalopathy is a rare disorder that typically follows a febrile viral illness. It's characterized by rapidly progressive encephalopathy to coma and seizures. It has these characteristic bilateral thalamic lesions. There are both sporadic and familial cases, and there are some important differences in how they present. And then there's associated high mortality with this condition, and early identification with prompt initiation of treatment with immunotherapy is important to improve their outcomes. And early treatment with high-dose steroids and IL-6 receptor blockade does show promising results. So thank you. These are my references. Sorry, I talked very fast.
Thank you, Dr. Runco. I wanted to open up the discussion for questions now. I might start with one, which is a little bit of a challenging question, but probably practically important. I think the common presentation of acute necrotizing encephalopathy can mimic something we see extremely often in pediatric neurology, which is, seizures in the setting of a fever. What would you use to sort of be able to differentiate or raise your clinical suspicion as to that a patient might have A&E versus and probably needs a more urgent evaluation as compared to an otherwise typically developmentally normal child who comes in with new onset seizures in the setting of fever?
I feel like I would say imaging, but that goes on to say that sometimes patients are diagnosed with a simple febrile seizure and are sent home. I think we got lucky in her case. She had focal seizures and also continued to have more seizures. I think that one's hard because I think it is easy to miss. I think the profound encephalopathy can be another way to differentiate these patients. These patients are very sleepy and altered, even not in the setting of the seizure. So trying to differentiate that from like a post-ictal could probably be helpful as well. And then just getting your just like routine lab workup, even a CBC and a chemistry might show your elevated liver enzymes and the platelet count, which would be, I think the thrombocytopenia would be unusual in a more benign new onset seizure.
Yeah, I asked a hard question because it's a really hard question. Like I think, right, we can't do a rapid MRI on every child that comes in, developmentally normal child who comes in with new onset seizures into the ED. It's just practically not possible. But I think what you highlighted are a couple things that for me personally, like I find useful. I think prolonged status epilepticus without return to baseline. That's important. I agree with you. Looking at the labs is really important. That's a really good clue in. If you see signs, I mean, that A&E severity score, looking at the liver function, looking at the platelets, looking at all of those things. I mean, if there's some small signs in a developmentally normal child with status epilepticus in the setting of a fever that, they got thrombocytopenia and transaminitis, I think these are things, and then you don't have a good exam. I think these are things to raise the alarm bells, raise the clinical suspicion, try to advocate for urgent neuroimaging, and you're still going to get patients who don't have A&E, but I think you're more likely to catch them if you find those things. I think looking at that CT scan is actually really important, not just accepting that the radiology read is that it's normal, but like thinking about A&E, cluing yourself into the hypodensities in the thalami. That is something that I think we've seen a number of times in the cases we've seen here. And I think the other thing is influenza. I think just honestly, and you're going to get false negatives, right? I'm not trying to say that that's not going to be a problem, but if you have a new, I do think if you have a new patient with a developmentally normal kid with prolonged refractory status epilepticus, with signs of some multi-system organ failure or thrombocytopenia and influenza A or B positivity, I advocate for the urgent neuroimaging just because they just increase the yield, even though you'll get the false negatives. So yeah, that's just my thought.
Yeah.
Poonam Bhatia asked, are we doing routine genetic testing?
So genetics was consulted just because Dr. Nielsen was even on service and is interested in this gene. I'm not sure if the genetic testing was being sent like in a different way, like through his lab or not. But I think genetic testing is planned to be performed. I just can't find it in the chart or the results, or I would have shared it with you for her.
I think I would say just based on our others can say if they feel differently, but I think just based on my general experience, we either get it inpatient or we arrange for outpatient follow-up, and that genetic testing gets done either in the hospital or in the outpatient clinic. I think most of our kids have, almost all of them, not sure about the most recent case, but almost all of our other kids have undergone genetic testing that I'm aware of.
Yeah, I would advocate for her too, just based on her family history and the sibling having that speech regression and the risk of recurrent episodes. But I will follow up with this patient in June and let y'all know.
Any other questions for Dr. Runco?
I had a question. This is Michael Kruer, and great presentation. I was curious, how you would tend to treat a case of suspected A&E, based upon the data that you were reviewing, the next time they come in.
I think it probably depends how severe they are. I think either way, I would lean towards empiric antimicrobial therapy, just proceeding with caution. And then I would also do high dose steroids and tocilizumab. I don't think I would deviate with like IVIG or Plex unless they weren't responding, or if there was something else that was telling me they were even more inflamed and needed more immune modulating therapy. I don't know if you feel differently. I guess the other thing I had discussed about this patient was it worth trying any kind of like mitochondrial support, even though like if they're just to help their efficiency, but I think in the end we all decided not to do that.
I think one of the things that I think one of the practical challenges that we have in some of these patients um, I think it's very hard in day one to have a specific diagnosis. This is even with the biothalamic diffusion restriction in the setting of an influenza A fever, status epilepticus, it's still A&E is still part of your differential. It's not, you don't make the diagnosis on day 0. However, others can correct me if I'm wrong, but the data, the data on treatment has across the board has supported that, the treatment early seems to be what's helpful. This is a cytokine storm. We don't think of this as, or at least I haven't seen anyone suggest otherwise, that this is something that happens very rapidly, very emergently within a 24-hour period. There's not a lot of evidence to suggest that the worst damage occurs in day 2, 3, 4. It's happening in that day 0, kind of emergent situation. So, I think I would advocate for, that early treatment. I think you need to do a number of things. I think you need to make sure that you need to get your LP, make sure this isn't a bacterial infection, rule out, cerebral sinus venous thromboses or other etiologies. Do your due diligence in terms of, making sure the risk of steroids or tocilizumab or whatnot are low in terms of what's on the differential, and then try to make a decision early. Just because it doesn't look like the data suggests that this is going to help, after those 24 hours. It's kind of something to look at early. I'd love to get cytokines and then make a diagnosis on these patients, but you're not going to get that data in the first 24 hours.
Yeah.
Yeah, I'm glad you mentioned that, Brian, because I think that's the difficult clinical situation we find ourselves in, is that we'd love to have the full data set to be able to make an informed decision. But just like you said very nicely, it seems like intervening early is very important for these patients in terms of long-term outcome. And yet some of these labs, for example, the cytokine panels are send outs. And so we're not going to get them in time to make some of these crucial decisions. So I agree.
Any other questions? All right, I think if there's no other questions, I think we can wrap up. Thank you, Dr. Runco, for an excellent presentation.
Thank you. Enjoy y'all's week.